Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome into the new episodes of our case histories, a series on gut-brain axis. Till now, we have discussed the IBS patient and then the functional dyspepsia patient. Today, we shall discuss a case history of post-infectious IBS patient. What are the symptoms, how these patients present, what are the signs, how we do approach treating these patients. We shall discuss this in today's vlog. The IBS post-infectious patient and gut inflammation. So it's a case history of 32-year-old male, previously healthy. He developed persistent diarrhea, bloating, and cramping after a severe gastroenteritis episodes, that's food poisoning, 6 months ago. So 6 months ago, he had a food poisoning, and after that, he developed persistent diarrhea, bloating, and cramping after eating. The symptoms worsen with certain foods, but do not completely resolve. So the symptoms are most of the times there, and they get worsened with certain foods. And there's a negative stool culture, and colonoscopy was done that was reported to be normal. So why is he still symptomatic? Question comes in mind. He had food poisoning 6 months ago, but till date he is symptomatic. Why? So the possible way is post-infectious IBS. This is one possibility. The gut-brain axis involvement is the second contributing factor. So let's understand how this post-infectious IBS patient develops. Up to 10% of gastroenteritis cases, they lead to IBS. And the mechanism for this is low-grade gut inflammation, dysbiosis, and altered gut permeability, that is the leaky gut. So almost 1 out of 10, they develop such symptoms. And what about the gut-brain axis involvement in such patient? Persistent gut inflammation, it leads to prolonged visceral hypersensitivity. And then there is microbiome changes, and these reduced gut serotonin production, and it affects motility. So these are the two main contributing factors how the post-infectious IBS patients develop. So what should be the management approach for such patient? This includes dietary modifications, pharmacologic interventions, targeting low-grade inflammation. So let's have a detail to know at some length the dietary modifications. The first management approach, or the first component of the management approach of post-infectious IBS patients. The short-term low FODMAP diet to reduce fermentable sugars. So you reduce them and it helps. Then probiotics, lactobacillus, bifidobacterium, these are used for microbiome restoration and they help. Then few words about the pharmacologic interventions. Rifaximin for IBS diarrhea predominant cases. Then peppermint oil as an antispasmodic and anti-inflammatory properties. Because of this peppermint oil has got these two properties, so it is of help for the cramps. Then the how to target the low-grade inflammation. Curcumin and butyrate supplements, that is the anti-inflammatory, they do have the role. And of course, the stress reduction to modulate gut inflammation, mind-body therapy. These are the two ways that we can reduce the low-grade gut inflammation. So what are the key message from this post-infectious IBS patient case history? IBS, post-infectious IBS, is not just bad luck after food poisoning. It's a gut-brain disorder with a persistent immune activation. So it should be taken that way. So just to remind the key takeaways from these case histories of the FGIDs. FGIDs are now called the disorders of the gut-brain interaction. DGBIs are real, they are not psychosomatic. The gut-brain axis dysfunction leads to visual hypersensitivity, dysmotility, and dysbiosis. The diagnosis is clinical, and it should be done according to Rome 4 criteria. Avoid unnecessary tests unless red flags are present. And multimodal treatment works best. And this includes dietary therapy, psychological interventions, and targeted pharmacology. And remember, the future lies in the microbiome-based therapies, that is the postbiotics, fecal macrobiota transplants, the gut-specific neuromodulators, that is serotonergic agents targeting the E and S. Let's continue the conversation. What's your biggest challenge in managing IBS and functional dyspepsia patients? Please comment below in the comment section. Thank you very much for being with me. Till now, we have discussed 3 case histories. Inshallah, see you on the next episode where we'll discuss the 4th case history. Till then, take care. Khuda Hafiz.